Rumination disorder is a feeding and eating disorder in which a person, usually an infant or young child, brings back up and rechews partially digested food that has already been swallowed. The repeated regurgitation of food over a period of at least 1 month. Regurgitated food may be rechewed, reswallowed or spit out. The repeated regurgitation is not attributable to an associated gastrointestinal or other medical condition, for example gastro-esophageal reflux, pyloric stenosis. The eating disturbance does not occur exclusively during the course of anorexia nervosa, bulimia nervosa, and binge eating disorder. If the symptoms occur in the context of another mental disorder, for example intellectual disability or another neurodevelopmental disorder, they are sufficiently severe to warrant additional clinical attention. In addition, infants with rumination may make unusual movements that are typical of the disorder. These include straining and arching the back, holding the head back, tightening the abdominal muscles, and making sucking movements with the mouth. These movements may be done as the infant is trying to bring back up the partially digested food. What causes rumination disorder? The exact cause of rumination disorder is not known. However, there are several factors that may contribute to its development. Physical illness or severe stress may trigger the behavior. Neglect of or an abnormal relationship between the child and the mother or other primary caregiver may cause the child to engage in self-comfort. For some children, the act of chewing is comforting. It may be a way for the child to gain attention. How common is rumination disorder? Since most children outgrow rumination disorder and older children and adults with this disorder tend to be secretive about it out of embarrassment, it is difficult to know exactly how many people are affected. However, it is generally considered to be uncommon. Rumination disorder most often occurs in infants and very young children between 3 and 12 months and in children with intellectual disabilities. It is rare in older children, adolescents, and adults. It may occur slightly more often in boys than in girls, but few studies of the disorder exist to confirm this. Regurgitation with associated rumination can occur in the context of a concurrent medical condition or another disorder, for example, generalized anxiety disorder. When the regurgitation occurs in this context, a diagnosis of rumination disorder is appropriate only when the severity of the disturbance exceeds that routinely associated with such conditions or disorders and warrant additional clinical attention. How is rumination disorder diagnosed? If the symptoms of rumination are present, the doctor will begin an evaluation by performing a complete medical history and physical exam. The doctor may use certain tests such as imaging studies and blood test to look for and rule out possible physical causes for the vomiting, such as a gastrointestinal condition. Testing can also help the doctor evaluate how the behavior has affected the body by looking for signs of problems such as dehydration and malnutrition. However, the diagnosis is mainly established by the clinical description of signs and symptoms, and invasive or costly tests are generally not necessary or helpful in making an accurate diagnosis. To help in the diagnosis of rumination disorder, a review of the child's eating habits may be conducted. It often is necessary for the doctor to observe an infant during and after feeding. Gastrointestinal conditions. It is important to differentiate regurgitation in rumination disorder from other conditions characterized by gastro-esophageal reflux or vomiting. Conditions such as gastroparesis, pyloric stenosis, hiatal hernia, and Sandifer syndrome in infants should be ruled out by appropriate physical examinations and laboratory test. Anorexia nervosa and bulimia nervosa. Individuals with anorexia nervosa and bulimia nervosa may also engage in regurgitation with subsequent spitting out of food as a means of disposing of ingested calories because of concerns about weight gain. What complications are associated with rumination disorder? Among the many potential complications associated with untreated rumination disorder are malnutrition, lowered resistance to infections and disease, failure to grow and thrive, weight loss, stomach disease such as ulcer, dehydration, bad breath and tooth decay, aspiration pneumonia and other respiratory problems, choking, death. In most cases, infants and young children with rumination disorder will outgrow the behavior and return to eating normally. For older children, this disorder can continue for months. Treatment. Treatment of rumination disorder mainly focuses on changing the child's behavior. Several approaches may be used, including changing the child's posture during and right after eating, encouraging more interaction between mother and child during feeding, giving the child more attention, reducing distraction during feeding, making feeding a more relaxing and pleasurable experience, distracting the child when they begin the rumination behavior. Aversive conditioning, which involves placing something sour or bad tasting on the child's tongue when they begin to regurgitate food. There are no FDA-approved medications to treat rumination disorder, but medications may be used to treat associated symptoms. Prevention. There is no known way to prevent rumination disorder. However, careful attention to a child's eating habits may help catch the disorder before serious complications can occur. Risk and prognostic factors. Environmental. Psychosocial problems such as lack of stimulation, neglect, stressful life situations and problems in the parent-child relationship may be predisposing factors in infants and young children. Functional consequences of rumination disorder. Malnutrition secondary to repeated regurgitation may be associated with growth delay and have a negative effect on development and learning potential. Some older individuals with rumination disorder deliberately restrict their food intake because of social undesirability of regurgitation. They may therefore present with weight loss or low weight. In older children, adolescents, and adults, social functioning is more likely to be adversely affected.